all clear.
Great. So, hello, I'm Andrew Bates from University Hospital Southampton. Just going to talk about my poster, which is reporting on the Encourage trial, which was a feasibility trial looking at a prescribed exercise program for patients undergoing neoadjuvant chemoradiotherapy prior to esophagogastric surgery. You'll all be familiar with the research which demonstrates that patients who are physically fitter at surgery tend to do better, reduced postoperative complications and some long-term beneficial effects. What we've previously demonstrated in our research group is that actually the neoadjuvant chemoradiotherapy negatively affects physical fitness, which is then associated with increased postoperative complications. So we wanted to undertake a trial to see whether we could train patients while they were receiving neoadjuvant chemoradiotherapy and to gather some preliminary effectiveness data. So we recruited patients from 2 hospitals. Those who undertook the trial all had a cardiopulmonary exercise test prior to neoadjuvant therapy beginning. Those who were randomized to exercise, we took the physiological data from the CPET to determine the intensities of their on-bicycle, in-hospital supervised exercise program. They did 2 sessions a week during chemotherapy and 3 sessions per week after chemotherapy, right up to the point of surgery. Really importantly, we repeated the CPETs every 3 weeks and adapted the training intensity according to any physiological adaptation. So from a results perspective, we think we can report good feasibility. Of the patients that we approached, about 45% said they did want to come into our program. Only 2 patients were withdrawn, and that was for medical reasons. Their pathway changed due to disease progression. And overall, 80 to 81% of patients completed all of the exercise that we gave them. The exciting signals that we got in terms of the preliminary effectiveness data were that yes, we could increase physical fitness, both during the chemoradiotherapy and even more so up to the point of surgery. So if you look at the graph in orange there, the dotted line represents the exercise group and the black complete line represents the control group. So you can see the control group trajectory is what we would predict from prior to neoadjuvant treatment starting to the end of neoadjuvant treatment. Their physical fitness dropped. The exercise group, we actually improved their physical fitness in response to the training, and that effect was then exaggerated up to the point of surgery. We can also say we're going to do some statistical analysis on this, but equally the length of stay was improved or was better in the exercise group. So just 3 days in critical care as opposed to 5 for the control group, and then 8.5 days length of hospital stay as opposed to 12 days in the control group. I will say all the usual caveats apply. This is a small study. We had a population of 22 patients, but it's a very exciting signal, and obviously one that we needed to try to see if we could reproduce it in an adequately powered randomized control trial, which we've started. It's called WESFIT. It was affected by COVID, as so many of these trials were. So we've moved our emphasis onto doing the supportive exercise treatments online in a big new trial called SafeFit. And the combination of all of this work gave us the HSJ Award, Cancer Care Initiative of the Year this year, which is wonderful recognition for us all and for the patients who gave in their time on the trial. Thank you.
Great, thank you, Andrew. So the observant of you will notice that I'm actually a named author on this, so it'd be great if you guys ask questions because I've seen this data before. So any comments from others on the session? Okay, so I will jump in. So Andy, what do you make of the length of stay data? Do you think there's any meaning to that, or is the study far too small to make anything of it?
Well, so I think it's a really exciting signal. I think we need to do some further analysis of it. So we're going to anyway have a look at see if it's statistically significant for us. Now, just looking at the numbers, I think if we don't reach statistical significance, I think it's most likely to do because the numbers are so small. I think for any patient, a length of stay in critical care of 3 days as opposed to 5 days, that's significant to the individual. And we hope we'll get statistical significance through. But if nothing else, it's giving us a really interesting signal, something that we can test in a large population as a primary outcome, which is of real importance to NHS England. So WESFIT we powered according to length of stay, which everyone will be familiar with is a difficult outcome to prove scientifically, but we're trying to get prehabilitation into the sort of standard clinical pathway for patients, particularly those undergoing neoadjuvant treatment. And NHS England, who funded WESFIT, wanted to know what happened to length of stay. So give us some. It's a very important outcome for patients, and it's a very important outcome economically in terms of healthcare resource utilisation and as a surrogate for postoperative complications.
Great. Thank you very much, Andy.
Thank you.
Next presentation is Dr. Daniel Ferry.
Hello, can you hear me?
Yeah, we can hear you.
Yeah.
So my name's Daniel Ferry. I'm a SHO over in Beaumont Hospital in Dublin. And this is a poster just of a clinical audit that we did earlier this year, looking at the accuracy of pre-operative record keeping in our hospital. So we did this because a lot of the times in recovery, you find patients' charts weren't completed at all, or were partially completed, which led to recovery nurses unsure as to the background of the patients. So the objectives of this audit was to look at the preoperative documentation and highlight areas for improvement, and to see the efficacy or the efficiency of preoperative record keeping in our hospital. So we created a performer which basically looked at the sections of the preoperative assessment chart and looked at 150 patients in the theatre recovery room over a period of a month. In that, we just checked whether or not parts of the record were entered or marked off. The results chart that we have here shows that of the 150 patients, 14 of them were emergency operations. There was no difference between any trends between elective or emergency theatres when it comes to record keeping. Some important results that we found were that only 27.3% of records were filled in to include that risks and alternatives were discussed with the patient, which is the consent part of the preoperative assessment form. So it's whether or not this is happening before and not being marked down, or whether or not it's just neglected as part of the preoperative assessment here, is to be debated. Other important factors that we found were related to the perioperative medical care of the patient. So factors such as the postoperative nausea and vomiting were only detected in 34.7%, and the BMI was only recorded in 17.3%, which leads, there's no way of knowing whether the anaesthetist at the time knew the data, but whether they had postoperative nausea and vomiting in the past, and did they affect their management because of this? It's hard to tell. Other important factors were that only 44% of people recorded an examination of the patient preoperatively, which again, this is documentation which has medical legal implications. Whether it was not filled in, there's no proof that the patient was examined. Same goes with the airway examination, dentition and Mallampati score. Even though 70% of people may have done it, that's still 1 in 3 people didn't record an airway examination of the patient. So what have we done since then? So we found since this audit that there's a need to emphasise the importance of the preoperative assessment among the NCHDs in Beaumont Hospital, and to especially emphasise the importance of documentation when it comes to risk factors and the risks being discussed with the patient, so consent. It's also been used to advocate for electronic-based records in the future, which may have some advantages over paper-based record that we have at the moment.
Great, thank you very much indeed. So, I mean, there's some interesting findings. The name and signature of anaesthetist. So there were some charts where it was, if I'm correct, it was not possible to identify who had anaesthetized the patient.
Yeah, that's correct. Yeah.
Goodness. And I mean, from a clinical perspective, as you've highlighted, the risks and alternatives not being discussed medico-legally is very challenging if anything goes awry, because it's hard. I guess unless it was documented on the consent sheet, to say that the patient had made an informed decision. Does this chart include the consent form, or is it separate from the consent form?
So the consent form is a separate form that's filled in by the surgeons, but the anaesthetists don't have a separate consent form in this hospital. So that is essentially the only part that has, the medical legal bearing, that the anaesthetist has talked to the patient and has discussed risks for consent.
Right, interesting. And if you, I mean, you speculate that electronic records might be better. Are you suggesting that you'd like not be able to proceed unless you'd filled in all the boxes, or just that it would be useful because of the prompts contained?
Well, the prompts, and again, even a not applicable option, or a reason as to why it hasn't been filled in, just something so that if you were to end up in a court, you could explain yourself out of not writing down the consent or recording some important risk factor.
And have you had an opportunity to present this data to your department?
No, so we've only just started back teaching and presentations of journals since COVID. So it's on the agenda, but not just yet.
Excellent. Might generate an interesting internal discussion, I would imagine.
Yeah, possibly.
Good. The name thing is very surprising to me. Not least because almost everybody who's written their name has actually written their IMC number, which seems very good practice. But yet some people have completely ducked writing their name altogether, which I guess there's a logic to. You're going to struggle to get caught if they can't find you. Thank you very much. Nice piece of work. Thank you. Okay, the next presentation is Juan Pablo Aristizabal.
Aristizabal. Yes. Hello.
Apologies. Please go ahead.
Okay. Hello. Everybody can hear me properly?
Yes, thank you.
Okay. Hello. Good evening. My name is Juan Pablo. I'm a consultant anesthesiologist and also the leader of the HPV department in my hospital. I work for the Clinic Assess, which is located in Medellin, Colombia. This is in South America. And well, let me tell you a little bit of the background. PROMs must be included in the healthcare pathway. Also, anesthesiologists should spend more time outside the theaters in terms of the perioperative pathway. In our system, the healthcare in Colombia doesn't apply PROMs often, and to be honest, we are not familiar with this term, which we decided to do this research. We decided to search the electronic medical record for the last year and a half and review all the Whipple's procedures. We collect 30 patients, and we decided to apply the questionnaire EQ5D5L, which basically have 5 descriptive analyses, which is mobility, self-care, usual activities, pain, discomfort, and anxiety, depression. And the last question is related to the general health evaluation. What did we find? We find that most of our diagnoses were pancreatic cancer. And surprisingly, 80% of the patients that we include in the research didn't have or have slight problems in mobility, self-care, and usual activity. But on the other hand, 20% of the patient report severe or extreme pain discomfort and were severe anxious or depressed after the surgery. So this really turned on the alarms in our hospital and in our department. So we decided to include psychology evaluation and chronic pain evaluation before and after the surgery in this health process. What can we conclude with this research? Application of this questionnaire of prompts is very, very easy and should be, well, not should, must be included and must be done routinely in our process. And this could improve the health care attention and in terms of perioperative pathway, and even more, we are talking about patient-centered care. Specifically in Whipple's procedure, general health perception of quality of life is good and patient could return to daily activities. And this really turned on the alarms to do more research, to do more studies, and really to take care on postoperative follow-ups to extreme pain and extreme depression. And hopefully with more studies, we could impact the healthcare system and really persuade our colleagues to include prompts in their healthcare. Thank you very much.
Great, thank you very much indeed for submitting from such a long way away. I couldn't quite work out in my head what the time was with you, but I hope it's reasonably civilized.
It's 6 hours behind, so it's 7 a.m. So it's really good because I thought I was going to speak at 12 at 9 or on a different schedule.
Good. Just how can you tell us how and when you collected the data and what the burden of the data collection felt like, how hard it was to get this data?
Was it easy? Really, because we have a good electronic medical record. We decided to do this in April of 2020, and we decided to do a 2 months follow-up. So we did this intervention in April and May. So we call all the patient and we apply this questionnaire by a phone call.
Okay. And at the very bottom, you've got a line which is best health you can imagine. How does that question work?
That question it's like a pain analog scale. So you ask the patient if 0 is the worst health you can imagine and 100 is the best health you can imagine. How can you describe your health right now? That Understood. Is the question that we gave to the patient.
Okay, and that's a range next to it. So nobody was at 100%, not surprisingly.
Exactly.
Excuse me. And can you comment on, so it looks like for quite a few of the questions, well, do all the people who have abnormalities overlap between groups, or are there a large number of individuals who have abnormalities in only one group, if that makes sense?
Could you, I don't understand the question.
So for example, on the first two, you've got mobility and self-care. They're both about 20%, so 80% normal. Are the 20% abnormal, are they common for those two groups or are they different people?
No, they're common. I mean, when we assess the patient preoperative, they usually don't have mobility or they usually don't have any problem with the self-care and usual activity. That's why if you look at the usual activity, you can see that 20% have problems with usual activity, but usually patient before surgery also have entered the surgery with some problems.
And it's the same people who are having mobility problems, the self-caring problems, the anxiety problems.
Exactly, yes.
Okay, great. Thank you. Very interesting data.
Thank you.
Next individual is Dr. Ryan.
Hello. My name is Maeve Ryan. I'm one of the SHOs at Galway Hospital. So this was just a brief audit of the consent practices amongst the NCHDs and I suppose their attitudes towards consent. So it's noted in the department there's fairly varying practice if you even just stand and watch people go through their pre-assessment process. And there is actually guidelines on this. So what we did was we had a look at the 2017 guidelines, and we just took a snapshot, I suppose, of some of the more interesting points that the guidelines had made, and we just looked to see in a survey if our NCHDs were following these. So the guideline aspects that we picked were basically, they suggest that consent should be taken as early as possible before surgery, especially in pre-assessment clinic. Written materials or online materials should be provided to patients, and consent should be documented. And then as a secondary aim, we just wanted to assess the attitude of our anesthesiology NCHDs towards surgeons and their involvement in the consent process, as often the surgical consent is more of a formal process, and they might mention just generally if it's going to be a general anesthesia or something like that. So we had a 60% response rate, which was pretty good for our surveys. Yeah, and so the results are pretty interesting. So only 50% of people responded that they always consent patients for a general anesthetic, and regional anesthetic was included in that. 38% outright said they didn't. And then 11% of people said that they always consent for regional anesthesia, but not necessarily for general anesthesia. With regards of documentation, only 19% of people said they documented either on the anesthetic sheet or in the chart that they had consented someone. 42% said no, and then 38% of people said sometimes. So regarding the timing of consent, we asked about the area that NCHDs were consenting people in, because we felt that obviously if they were consenting them in the theatre reception on the day of surgery, that's not exactly giving them time beforehand. And unfortunately 92% of people said the most frequent place they consented people was in the theatre reception, and only 8% said that was on the day before in the ward that they'd gone to speak to the patient. And 42% of the NCHDs felt that consenting people on the day of the surgery wasn't adequate time for them to process what had happened. Only 8% of people gave materials in pre-assessment clinic. And then when we asked people, 38% said they felt the surgical team did have a role in starting the consent process for anaesthesia, which was interesting. So what we're aiming to do going forward to improve our standards, because we weren't delighted with our results. So our anaesthetic sheet doesn't have a specific place to document consent. So that's something that we'd like to start on, just to see that people are doing it. And also for our pre-assessment clinics, we're hoping to get permission from the consultants running that to develop a material that people can give just a general overview of the risks and the procedures involved in general anaesthetic and in the regional anaesthetic techniques that we use here in the department. Thank you.
Thank you very much. Do you know what information gets sent to your patients routinely? So when they get their invitation to see you, do they get any information about anaesthesia at all?
So no, they don't. So essentially what happens in our hospital, the process is that most patients are brought to a pre-assessment clinic, which is now, unfortunately, due to COVID, over the phone. So they will just get contacted by our pre-assessment nurse to say they'll be getting a phone call, and then it's up to the anaesthetist on that phone call whether or not they even suggest which type of anaesthetic the person will be getting for that procedure. And there's no formal letters or documentation or anything existing currently to be sent to them.
Right. And does everybody speak to an anaesthetist though in that pre-assessment? So every patient will have had a direct conversation with an anaesthetist before they come into hospital, or not?
So not every patient. So we have 4 emergency theatres actually. So most of those patients haven't spoken to an anaesthetist, say, unless it's in the reception before they go into the actual theatre. And every so often we do have elective patients, I suppose, slip through the cracks in that we have some direct access day cases that wouldn't necessarily come to pre-assessment if they're relatively low risk, say grade 1 or 2.
Yeah. I guess linking to some of the other presentations, do you have an electronic medical record, or is there a plan to get one? Would this be integrated within that?
So we actually do have electronic records, but they're relatively new, and they are very useful in that when they've been properly uploaded, you can actually see previous anaesthetic sheets and that, which is really excellent. But unfortunately, it's not consistent across all patients, and a lot of the time stuff is still missing. So we're working on it. We're certainly getting there, but it's not perfect at the moment. Right.
It's I hope not too many lawyers watch some of these abstract presentations. Some of them are just quite challenging. But very useful presentation. Thank you very much.
Thank you.
Next presenter is Dr. Taylor.
Hello, can you hear me all right?
Yes, thank you.
Brilliant. So afternoon, everyone. My name is Rhys Taylor. I'm a SHO at NHS Tayside, Nine Wells Hospital. And today I'm going to be talking about the green pathway, which is a perioperative pathway designed to minimise the risks of our patients contracting COVID-19 at a point when they're particularly vulnerable. And this pathway first became operational in April when our patient started isolating, and a first operation was performed on the 8th of May. So there are 3 key phases: the pre-admission, admission and discharge. Pre-admission is very similar to pre-COVID in that the patients have a pre-assessment clinic. However, they have their investigations, excuse me, these patients also now have their investigations expedited, and we try and minimise patient healthcare interface at this point to minimise the risks of either party contracting COVID-19. These patients, once they're optimised and consented for the green pathway, enter a pool of patients, and from this pool, the clinical prioritisation group lists patients for theatre in the coming weeks. This prioritisation group is made up of senior surgeons, anaesthetists, waiting list coordinators and other interested parties. And when a patient has their date for theatre, they attend for a day 0 swab. They then have to go home and isolate for the next 14 days and have a domiciliary day 11 swab. Assuming both swabs are negative, they then are admitted to the green zone of the hospital, which is an isolated bubble separate to the rest of the hospital. It's separated geographically. It also has separate staff. On the day of admission, the patients have their operation, and then their care continues on the green pathway post-operation or post-operatively. Once the patient is ready for discharge, we advise them to isolate for a further 14 days as well. So to date, we've, or as of the 20th of last month, we've had 398 patients enter the pathway, 381 of whom have been discharged. We've performed 815 pre-admission and 101 inpatient COVID swabs, all of which have been negative. As part of this data collection, I follow up on the data 14 days post-discharge to see whether the patients have any further healthcare inputs or whether they're readmitted. The vast majority, 317, haven't been. However, 23 patients have been readmitted during that time period. Vast majority for issues with the surgical wound or surgical sites, but also patients presenting with non-specific symptoms. At this point, we're continuing to try and develop the pathway, putting in more resilience into it in preparation for further spikes in the Tayside area. And we're particularly excited and proud that our pathway is being picked up on and adopted by SIGN, which is the Scottish Intercollegiate Guidelines Network. And they've based their recommendations for a perioperative pathway on NHS Tayside's green pathway. Thank you very much.
Thank you very much. Very interesting and very obviously topical data. So a couple of questions. How do you manage separate staffing, and are the staff regularly tested?
So the staff aren't routinely tested unless they were to start exhibiting symptoms or if they were to be exposed to someone as normal. The staffing, nursing staff and ward staff is always the same, and the pre-assessments junior doctors always the same for the green zone. The differences come in when, for instance, surgeons come to see their patients. Obviously, then they aren't specific to the green zone. So there's a real drive to make sure that anyone who's visiting from separate locations in the hospital wash their hands very carefully and meet all PPE measures, and also that people don't routinely come to the green zone unless they have a very specific reason to be there, and if they are there, they minimise their visits.
So arguably the greatest risk is those individuals sort of penetrating into that bubble that's otherwise looks pretty secure.
Yeah, I think that's a fair assessment. Yes.
And in the writing, you say that the patients isolate for 14 days with support from the pre-assessment team. What sort of support have you been offering them?
So whilst they've been isolating, they routinely have 2 to 3 phone calls. We let them know the results of their test, of course, but we also call to check up on them. We check whether they've had any symptoms consistent with COVID, how they've been doing mentally and physically during this time, and also if they have any questions. I think this almost feeds into one of the earlier presentations we've just had about consent, in that it's making sure that these patients fully understand what's going on, don't have any issues during this time, and it's also trying to preempt any problems before they become a real issue, particularly considering that once this patient is admitted, we want them to be going for their operation that day.
Great. Thank you very much indeed.
Thank you.
Next presentation is Dr. Blake.
Yeah, hello everyone, I'm Aaron. I'm an anaesthetics SHO in Cork University Hospital in Ireland. So the title of this presentation, this research, is Characterization of Rebound Pain Following Axillary Brachial Plexus Block. So essentially, as most of us know what rebound pain is, it's a pain that a patient experiences post a peripheral nerve block it's kind of disproportionate to what we expect afterwards. And what we aimed to do was to characterize that in terms of the description of it, the timing of it, and the severity of it. So there's a couple of different theories about what causes rebound pain, including memory pain receptors and the neurotoxic effect of local anesthetics as well. So, but the problem is that there is no prospective research going forwards. That's what we aimed to do to characterize it. So it's an ongoing study at the moment. This is quite a small sample size, but what we're aiming to do is a case series of 20 ASA 1 to 2 patients who are all coming in for mainly forearm type fractures, wrist and radial RIFs for operative fixation, and we consent them before their procedure. We then ask them to complete a 24-hour pain diary from pre-block until the first post-operative day, and this includes hourly pain scores and adjective descriptions of the pain as it happens. So then this, and also we ask them to do it at rest and on movement, and try to compare that to when they arrived for the procedure in the morning. So we also collect data on the intraoperative analgesia given, the type of block that's given, etc. So in terms of results then, so far we've had 6 patients, and on arrival patients had a mean score of about 4.0 at rest and 6.3 on movement, as would be expected, a little bit more severe movement. All patients received lignocaine 200 to 400 milligrams. 2 patients also received bupivacaine 0.5. 2 patients also received lignocaine and an epinephrine mixture. So 4 out of these 6 patients at the moment, so about 66% experienced rebound pain at a mean of 4.25 hours post their block. So this is kind of consistent with the literature at the moment, which says that about 40% of patients experience rebound pain. So I imagine this is a little higher because our sample size is small at the moment. But the mean intensity of the reported pain at onset, that is when it first happened and they first noted, was about 4.25, and then the mean intensity of the most severe rebound pain during the duration of it was found to be about 6.5. So adjectives that patients then filled out on the pain diary to describe the pain included mild, distressing, aching, stabbing, shooting, gnawing, burning, throbbing, like fear. One patient described it as fearful. So this was kind of the actual rebound pain itself. We also have data to compare how they described it when they first arrived in theatre. So then the time to first post-op analgesic requirement was about 136 minutes. 4 patients also received paracetamol intraoperatively at the time. So 1 patient received morphine and fentanyl intraoperatively, 1 received diphenol intraoperatively. Then all patients who experienced rebound pain, when they were followed up, had used 1 gram paracetamol 4 times daily in the post-op period, and 1 required morphine within 5 minutes post-procedure. So basically then what we did here was just a small scatter plot for the limited data we have at the moment, but what we're plotting here on the y-axis is rebound pain severity, and on the x-axis is time post axillary brachial plexus block. So at 3 hours, 1 patient described the rebound pain severity at onset as an 8 out of 10, 1 patient described it as a 3 out of 10 at 4 hours, and then 2 patients at 5 hours post-block and described it as 2 out of 10 and 4 out of 10 in severity. So there is a bit of a range in terms of severity and timing, but we're hoping that this will become clearer as the study carries on. So I suppose what our preliminary results or our interim results tell us is that, yes, we do know that rebound pain exists. We've always known that, but we're able to start characterizing it now so that we can research into risk factors and hopefully develop some strategies to prevent it, as it's there's not a whole lot of prospective research. Thank you very much.
Great. Thank you very much. I guess, I mean, obviously small numbers, but if I understand you correctly, some of the patients had analgesia intraoperatively and some did not. And then you described the analgesia they subsequently needed postoperatively. Did you get any flavour that those who had adjunctive analgesia intraoperatively didn't get rebound pain?
So the data that we have says that all the patients who did actually get the paracetamol and the intraoperative analgesia have experienced rebound pain still. So I suppose that's something that we need to analyze a little bit further, but it's looking like it's not a factor in determining whether they will experience rebound pain. Maybe in terms of severity, I know that the patient who experienced 8 out of 10 in severity had actually received both paracetamol and diclofenac intraoperatively, but still experienced a very severe type of pain 3 hours post their block. So yeah, it's something that we definitely need to look into a bit more.
Great. Okay, thank you very much indeed.
Yeah, thanks.
The next presenter is Dr. Caulfield.
Hi, how are you? Thanks for having me present my case today. So I wanted to highlight an interesting case that I encountered. Can you hear me okay? Sorry. Yeah?
Yes.
Well, it's in the PACU at UCLH. It highlights the incidence of euglycemic decay during an elective laparotomy in a patient for ovarian cancer secondary to SGLT2 inhibitors, and their management in the perioperative period, because there's been a few changes to kind of recommendations in the last couple of months. So SGLT2 inhibitors are licensed in Europe for the treatment of type 2 diabetes only, although there's research ongoing that they may actually be quite beneficial in type 1 diabetes. The current AGBI UK guidelines suggest that they should be stopped the day of surgery. However, there's been recent warnings both from the UK, FDA, and Australia and New Zealand that may actually alter these recommendations. I identified the following case of a 76-year-old lady who was post-midline laparotomy for ovarian cancer, and she was admitted to her PACU for post-op observation. 1, because she had a laparotomy electively, and 2, she had significant comorbidities. She was quite frail, type 2 diabetes, hypertension, and hypercholesterolemia. She underwent a general anesthetic and a spinal, and quite notably on handover from the anaesthetist on arrival to PACU was that she had quite labile blood pressure intraoperatively, and she had this profound metabolic acidosis that, despite minimal blood loss and quite significant fluid resuscitation of 3 litres, with adequate urine output and normal renal function pre-op and post-op, but they couldn't figure out why she had this profound metabolic acidosis. And you can see from the first ABG, pH is 7.194, PCO2 is 5.15, PO2 is 30.9, which is good. Blood sugar was normal, 8.1, lactate 8.9, but she had a bicarb of 14.8 and a base excess of 13.2. The day team at that point, so I was on the night shift, so the day team had started an IV bicarb infusion because they hadn't realized what was happening, and it made her pH look better, but she was decompensating further from a respiratory point of view. So PCO2 was 4.38. She was becoming increasingly tachypnic with not a huge improvement in her base excess and her bicarb. So if you note that she's in relation to her medication, then she's on lisinopril, cyanocobalamin, or vitamin B12 replacement. She was on 4 antihypoglycemics, including an SSGLT2 inhibitor. I can never pronounce them, so apologies. Paglifloxin was the one that she was on. So once I realized that she was on this, I checked her ketones, realized that they were 4+. So we only had means of checking urinary ketones, which is not what's actually genuinely recommended. But after starting an IV insulin infusion and putting her on IV dextrose to compensate for the insulin infusion, her gas improved significantly, pH 7.4, PCO2 was 4.46, bicarb was 21.5, and her base excess was minus 3.9. So a very accurate diagnosis of euglycemic DKA. So the reason that this was highlighted, I suppose, the benefit in hindsight as well, is that I spent time in Australia and as a fellow, and then Ireland, and then the UK. But in recent guidelines, the UK in March, so I don't know if this might have been lost in translation with COVID, etc., but the recommendations from the UK was to stop before major surgery or an acute serious medical illness, the SGLT2 inhibitors. And blood ketone levels should be measured preoperatively. Now, the recommendations are quite vague. It's like, how long they don't answer how long should they be stopped before surgery? When can I restart them? At what point do I check ketones? If the ketones are high, what do I do? There's no kind of guidance or recommendation. And the AGBI guidelines haven't altered in accordance either. The FDA then, around the same time in March 2020, came out with further recommendations that they should be stopped for 3 days before surgery, but no other kind of information what should be done. I suppose in Australia and New Zealand, they use this drug maybe potentially a lot more frequently than in the UK or even Europe. So maybe they're seeing a lot more of it. But when I was there as a fellow, we were admitting patients to ICU inappropriately when the SGLT2 inhibitor hadn't been stopped, and they needed to be on IV insulin infusion for several days. So they needed, it was inappropriate, well, potentially avoidable admission to ICU. They have since published recommended guidelines, which are really in-depth and very accurate in what should be done. They recommend holding the SGLT2 inhibitor for 3 days before surgery. Hyperglycemia is a potential risk, so they recommend increasing the dose of the other oral hypoglycemics if needed. The morning of surgery, the blood ketones need to be checked, and if they're high, then a metabolic acidosis needs to be outruled. And if the base excess is greater than -5, depending on the issue or the surgery that's been done, they recommend actually postponing surgery and correcting the potential euglycemic DKA, and then proceeding with surgery. So in conclusion, what's happened as a result of this case, we have changed our local, against the UK guidelines, we've actually changed our local guidelines for the use of SGLT2 inhibitors through the diabetic team here and the perioperative medicine team and guidelines to stop them 2 days before surgery. We had no way of measuring blood ketones on our unit, so we have now gotten a blood ketone monitor, both in our unit here in West Warren Street and also at UCLH. I've also been in contact with the AGBI, and I'm writing a book chapter for UCL and submitting a letter to anaesthesia highlighting this needed change in guideline, and hopefully that will have an impact in terms of both local and national recommendations for SGLT2 inhibitors in the perioperative period.
Brilliant, thank you. Very, very interesting case. I'm afraid we're out of time, so you won't get the treat of having questions, but thank you for the presentation.
Okay, no problem. Thank you.
Dr. Ferry.
Hi. So myself again, Daniel Ferry, SHO in Beaumont Hospital. It's just an audit that we carried out looking at post-operative critical care admissions from theatre. This was carried out because it was the experience of some consultants in the hospital that oftentimes there was bed shortages in ICU, which made it difficult to get patients into critical care beds following elective theatres, elective surgery. So there was also a plan to look at the scoring system, the surgical AFGAR scores, to look at whether or not we can identify high-risk patients in the intraoperative period, so more time can be given to optimise the bed resources in critical care. So the objectives were to evaluate the availability of critical care beds for post-operative surgical patients in Beaumont Hospital, and whether there were any implications of bed shortages or why patients did not end up where they were planned to end up post-operatively. And also to look at the perioperative risk of patients admitted to critical care from theatre. So what we did was we looked at the theatre lists over a period of a month. This was cut short due to COVID, but there was enough patients in the study. And we recorded any pre-planned admissions to critical care. We then looked at the recovery room logbook and the electronic critical care system and looked at who was admitted to the critical care units post-operatively to look at the actual destination post-op. And then we compared the medical and anaesthetic records to look for any documentation of reasons for change to the same, as well as looking at the intraoperative data for the surgical Apgar score. So looking at the results, 61 patients were earmarked for critical care beds preoperatively. And the pie chart there shows you that 4 of these patients ended up in a different destination as that was planned. 2 of these patients were admitted to a different critical care bed due to bed shortages. So those who one was due to go to HDU ended up in ICU because of no shortage of HDU beds, and one was due to go to general ICU and ended up in neurology ICU. And the other 2 patients were instead admitted to high dependency areas of surgical wards, which are areas which have a 4-to-1 nursing care rather than 2-to-1, which may be in HDU. There was no documentation in these patients' charts as to why this was the case, whether or not it was no longer required or whether there was a bed shortage. There's no way of knowing. 3 patients had unplanned admissions to critical care, secondary to intraoperative complications, which is about 4.8%. Looking at the surgical Apgar scores for the intraoperative risk, there was a study that was carried out looking at in the Journal of Gastrointestinal Surgery, which looked at the surgical Apgar score, whether it can predict the need for post-operative ICU admission. They said that the cutoff would be 7 for a majority of patients for an ICU bed, which is what we saw in our data, that 7 was the average surgical Apgar score for patients requiring admission to ICU in Richmond ICU, which is the neurology ICU unit in Beaumont, and 8 was the score for HDU. A lower surgical Apgar score is a higher risk. So from this data, we found that bed shortages do impact upon the post-operative destination of patients, but often there's either a lack of documentation as to why they go to a different bed, or patients are admitted to a critical care unit which is of equal or higher nursing care. So again, there's a risk here of medical legal issues, the lack of documentation, not explaining why patients are in different locations as to what the plan was. And then also there's a talk of integrating a risk score into the anaesthetic record, such as the surgical Apgar score, so that more time can be given to plan for post-operative beds. Now, surgical Apgar score only looks at intraoperative patients' data, so a preoperative assessment score, risk score, may also be of use. Thanks.
Thank you very much. Do you have a feel for how much of this is input burden, i.e. too many patients going in, and how much of it is downstream blocking, i.e. the inability to get patients out because other bits of the hospital are clogged up?
So it felt more of by looking at the patients who were in ICU at the time, it was more of a patients not being able to leave ICU. So difficulty there rather than getting patients, rather than there being too many patients coming in.
So if we're able to manage the flow through the hospital, we might actually have enough ICU beds.
Yeah, exactly. Yeah,
which I think is a common experience. Brilliant. Thank you very much for that. The final presentation is Dr. Ryan.
Hi there. So my second audit it's an audit looking at the handover process in the recovery unit in Galway Hospital. So it's just a brief snapshot really. So basically the concept is that we'd noticed from our time in Galway that it tended to be a pattern that the handover between the anaesthetist and the recovery nurse was frequently interrupted. And we know that this handover point is really important for patient care. Interruptions and ineffective handover can lead to drug errors, and it can also lead to incorrect monitoring of the patient, especially if it's something like a patient with COPD who we're setting parameters for. So what we did was, for a period of 1 week, we observed handovers taking place in our recovery unit. And so what we define as an interruption, it had to be significant. So it had to be an event that caused either the anaesthetist to actually stop speaking and have to wait, or for a piece of information to be repeated. So for the recovery nurse to repeat something that had already been said. And so what we found, our numbers were relatively small, only 20, but 50% out of those 20 were interrupted. So the most frequent offenders were actually searching for the patient's ID band, particularly if it had been removed from the arm for some reason and put on the chart. We noticed that this seemed to be a major source of distraction. The other source of distraction was other staff members who weren't involved in the handover process coming in and interrupting it to ask a question that wasn't relevant to what was going on at the time. And then the other major factors we noticed was setup, essentially. So setting up the ECG monitoring, flushing of peripheral lines, and then infrequently enough, we had one incident where the handover was interrupted to ask the patient their pain score in the middle of this. So what we'd seen was, from our brief snapshot, there was a high rate of interruptions, which we were expecting that from what we'd seen previously. It mainly seemed to be around the setup before the time of handover. So we noticed the main areas that could be improved was that if the patient had just been checked in, so the ID band had been checked, and if all of the monitors had been set up and all peripheral lines had been flushed before starting the handover, this seemed to be an area that would dramatically improve the quality of the handover between the anaesthetist and the recovery nurse. So we had a bit of a think about what would be the best way to try and encourage this practice. So we felt that perhaps visual cues, so that was our aim. We're in the process of trying to develop essentially posters just to remind people to adequately set up and to not come in and interrupt as well the handover process. And then we're aiming to, after 1 month of these posters being present, have a look and see if it actually had any effect, or if we need to go back and think about a different intervention to improve our handover process in the recovery room. Thank you.
Thank you very much. Do you have, I understand it wasn't part of the data you presented, but do you have any feel for the consequences of an interruption in terms of the effective transmission of information?
Yeah, so I suppose we didn't document it and collect it, but it would have been something interesting to look at. I suppose one of the factors that actually drove us to do this audit was we noticed that it was quite frequent practice for the recovery room to ring back to theatre, asking for the most frequent questions were around drugs, and also around that piece on I suppose vital monitoring. Just ringing back to ask if certain vital parameters were acceptable when it would have been handed over in the handover process, that was normal for that patient.
Yeah, it's interesting. I mean, I think that the analogy with flying is sometimes overdone. We love to do it, but equally, if we were watching another set of professionals doing their handover, we might be a bit disturbed. We saw them being multiply interrupted and not obviously exchanging information very effectively. So I think it's
exactly.
Yeah, it's a very neat audit. So thank you very much indeed.
Thank you.
So thank you everyone.